Good morning, everybody. A warm welcome to everybody. Following the success of the first IHB International Rheumatology Conference, I welcome you all to the second IHB International Rheumatology Conference. It is my pleasure to introduce to you Dr. Emil Hanna, Conference Secretary of today's conference and Head of Rheumatology at the International Hospital of Bahrain. Welcome, Dr. Emil Hanna.
I would like to welcome, in behalf of the International Hospital of Bahrain, I would like to welcome all of you to our conference. Your Excellency, Mr. Sadiq Al-Shehabi, Minister of Health of Bahrain, Mr. Faisal Al Zeerah, President of International Hospital of Bahrain, Professor Badawy, President of our conference, Your Excellency, Ambassadors, eminent guest speakers, my colleagues, ladies and gentlemen. It gives me great pleasure to welcome you all to the second IHB International Rheumatology Conference. The idea of this conference, inspired by Dr. Faisal Al Zeerah, President of International Hospital of Bahrain, in recognition of rheumatology being outstanding service offered by IHB to the residents of the people in the Kingdom of Bahrain. The scientific committee, headed by Professor Badawy and moderated by myself, worked hard to invite international speakers as well as speakers from our region to ensure a highly scientific program covering various aspects of rheumatic diseases as well as osteoporosis. I hope that you all enjoy our program and a nice stay in Bahrain for our guests. Thank you very much.
Morning, ladies and gentlemen. Mr. Sadiq Shehabi, Minister of Health, Mr. Faisal Zeerah, President of the International Hospital of Bahrain and CEO. Ladies and gentlemen, it's my pleasure to welcome you here today in the second Rheumatology Conference of the International Hospital of Bahrain. It gives me great pleasure also to welcome our foreign guest speakers who came from Italy, Germany, USA, and Egypt. And I believe that the first Congress 2 years ago was a success, and this is what drove us to make the second one, and we hope that will be as successful as the previous one. Rheumatology have developed during the last 50 years, because almost 150 years ago, the only treatment we had for rheumatoid arthritis was aspirin and salicylates. Now we have passed the era of glucocorticoids, which was discovered in 1948 by Philip Hinch of the Mayo Clinic in the States. Now in the era of using biologic agents, which are targeted therapies to certain cytokines, which cause destruction of the synovial membrane and the joints as well. Osteoporosis has developed in the last 25 years. Osteoporosis was known as an orphan disease, where it was no man's land. It's a multidisciplinary disease which has been seen by rheumatologists, orthopedic surgeons, endocrinologists, gynecologists, and obstetricians, but it didn't have the attention until 25 years ago for so many reasons. But now we have so many remedies. We have an armamentarium of drugs which we can use in the treatment of osteoporosis and to prevent its first endpoint, which are the fractures. I think we have worked hard to come up with a successful Congress. The contents of the scientific event is really a good quality, and I'm sure that this Congress will put itself on the international agenda of many other congresses worldwide. I would like to thank the drug companies who sponsored and supported this meeting. I'd like to thank Emil Hanna for working very hard, Chris, and all the people who have helped them. I wish you a very successful Congress. Thank you very much.
So today I will try to drive you inside what is the up-to-date in rheumatoid arthritis criteria and therapeutic perspectives that we have for the future. But in particular, where are we now today? I don't know how many of you are familiar with this, but however, I will try to remind you about which are or which were and are now the classification criteria. So in 1987, we had the first American College of Rheumatology criteria that were, we say performant, but still they had a problem. And the problem is, as today we have in all rheumatic diseases, these criteria were not able to catch the early disease. This is a very important issue, and I would like you to really focus on the fact that today we want absolutely to catch this patient in the very early phase of the disease. Now, the current trends is today that we need to recognize the patient as soon as possible. We need to, in particular, to treat them as soon as possible. And obviously, we have a lot of new drugs coming up. Popping up every day, you have new drugs, and I will present to you some of these drugs. So, a common effort between Europe and America, United States, has been to create new criteria to be able to see this patient evolving from the early phase up to the most advanced phase. So that's the reason why Americans and Europeans together have elaborated new criteria. Why? Because one of the main aims of a rheumatologist today is to avoid the evolution of the disease and to avoid in particular the erosion of the bones. Because rheumatoid arthritis is a very aggressive disease that is entering the joints and progressively eroding cartilage and bone at the same time. So think of this and think that such a disease can start eating down the joint after 3 months from the very early onset of the disease. And usually our problem, and we know this, that the disease diagnosis is late. So if you make a diagnosis 6 months later or 12 months later, you already know that this patient is erosive. Erosion means loss of function. And this is what we don't want. So as you see here, an erosion is classified as a cortical break.
You say that a physical condition, rheumatoid arthritis, fibromyalgia, certainly in the realm of rheumatology, can you say that one of the things that causes it is psychological stress, anxiety, depression, these mental conditions? Can they actually lead to a physical result? And I think that we'll be able to explore that through looking at the relationship between these by making definitions very clear about what we're talking about when we talk about psychological conditions and what we're talking about physical conditions. In the end, I'm sure that everyone here knows that there will be a complex relationship between physical conditions such as stress, anxiety, and depression, and physical conditions such as fibromyalgia or rheumatoid arthritis. That it may not be clear which is causing which. This slide it describes a segment of the field of psychoneuroimmunology, and this is the proposed connection between the mind and the immune system, the psyche, and its effect through the brain on the immune system. And just to summarize, we'll come back to this slide again, but just to summarize, there are stressors that you might consider as possible influences on the immune system. Physical stress and psychological stress are both possible contributors. And they do have powerful effects, as been shown in many preclinical studies.
Now, ladies and gentlemen, we have almost half an hour for discussion, and the first paper to be discussed is the one which was presented by Professor Marco Serenic. It's about update on rheumatoid arthritis criteria and therapeutic effectiveness. Anyone wants to ask Professor Serenic? Can I just start by asking you, Marco, do you think we are having now an influx of biologic agents, and the last one we have with the Janus kinase, small molecules, and so on? How much do you think that the problem of consolidating or initiating a remission and consolidating it in a patient with rheumatoid arthritis who has been given biologic in addition to methotrexate or other DMARDs, how much of the problem was solved? Did we achieve a better progress, or it's, we are more or less going forward and backward most of the time?
For sure, thank you, Samir. For sure, all these drugs together, when they are starting very early, they will give you really the best result. So this is sure. We know this. So when we have a young patient, a young lady with rheumatoid arthritis in the first 3-6 months, and we can hit the disease with combination therapy, with synthetic disease-modifying drugs together with biological drugs, we can get the best result out of it. Now, what is not clear to us is for how long shall we keep this patient under this regimen. So this is the problem that we have today, and we don't have yet the real answer to this, because the time is too short from the moment we have started the treatment with biological therapies in our profession. So, we are facing the fact that we have to start, and we know this, but we still do not know for how long shall we keep the patient under this kind of regimen. Or we shall have to withdraw, or we shall have to make gaps in the treatment. We know that when the disease is active, you strike with the regimen, the treatment regimen, you stop the disease evolution, then if you stop after 6 months, 12 months, the disease will relapse. We know this for sure. But then for how long, for how many years, we shall keep the patient under this control, tight control, we don't know. Probably now we are starting some experiences in reducing the drug and making gaps with biological, keeping the synthetic always, and then coming back if something moves with the biological. We are trying to do this.
My question is for Dr. Marco. I have a patient with a linear scleroderma, morphia.
It's very unlikely that a localized scleroderma can become systemic. There are some cases described, but it's very unlikely, hopefully. For linear scleroderma, it depends how much is the extension, which is the age, if they are children or they are grown. Usually they are children. However, if it's just morphia, 1 or 2 patches, you can use methotrexate and steroids. But if it's a linear scleroderma, or it's a coupe de sabre, or is a fascial hemiatrophy, you should be very, very aggressive. The case where you must be aggressive, and even we transplant them, is the generalized morphia that is a terrible disease.
I just want to give comment to Dr. Ghanimi. I said it is traditionally divided into organ-specific and non-organ-specific, but this classification is artificial, and I mentioned this one clearly in the presentation. This is artificial presentation, and the aim of this presentation is to show the overlap between the non-organ-specific or organ-specific. This is very important, this number one. So it is pointed out clearly it is artificial. Number 2, regarding the management. Our target for the management, if we can keep healthy gland early, we did not say we have to wait until the gland is totally permanent. We just put in a question, like for example, in autoimmune disease, we have only diabetes prevention trial, which showed for autoimmune disease, which shows some improvement. But for other glands, there is no prevention trial. So it deserves that we can make trial. If we can save the gland to the patient instead of waiting until the gland is totally permanent and then you give hormone replacement therapy, we don't know which will be more better, healthy gland or to wait until the gland is destroyed and to give hormone replacement therapy. It just needs further recommendations. Thank you.
Thank you very much indeed for being here. All our efforts and preparation were rewarded by you being here. I am most grateful to you, Samir. You really masterminded this, and Nabil also, and Chris, and all the people you have mentioned, really very grateful to you for leaving all the snow and coming down here, and all of you who have made it a great success. You are right. It was one of the most intellectual boiling points, and we really enjoyed listening to you, all of us. Thank you very much indeed, and God bless you, and we hope that we'll see you very soon. And for those of you who have been here and sitting there, it is for you. We did it for you. You deserve it, and we look forward to seeing you next time here. And I'd love to see your smiles and you're enjoying it, because I did. Thank you, and God bless.